Thank you, Ahmed, for the invitation to talk today, and thank you all for joining me. My talk today will look at the application of advanced imaging in prostate cancer. We don't have enough time for me to go into details about how I interpret an MRI or PET scan, but more importantly, I would like to discuss how advanced imaging can help to optimize the patient outcomes at different stages of prostate cancer. During my talk, I will regularly come back to the letter P, and not surprisingly, the first letter P is P for prostate. During their lifetime, 1 in every 6 to 8 men will be diagnosed with prostate cancer, and about 20% of men will have unnecessary biopsy due to a falsely elevated PSA level. Not that long ago, we relied on less sensitive modalities in the diagnosis and staging of prostate cancer. In the last 8 to 10 years, there has been significant progress in advanced imaging in the field of prostate cancer. We will start chronologically at the beginning with detection. Over the last decade, multi-parametric MRI prostate has become an essential technique in diagnosis and management of prostate cancer. Between 2017 and 2018, we have 2 very important landmark clinical trials coming from the UK, PROMISE and PRECISION trials that changed practice and established MRI prostate as the first line in detection of prostate cancer, moving away from decades of truth biopsy. PROMISE and PRECISION trial demonstrated that multi-parametric MRI prostate has superior diagnostic accuracy compared to truth biopsy, transrectal ultrasound biopsy, with a sensitivity of 93% compared to 48% with truth biopsy. Population of men under MRI triage also had other advantages, including about 28% of men avoided a biopsy, fewer biopsy calls required, less complication compared to truth biopsy, higher detection of significant prostate cancer, and also less detection of insignificant prostate cancer. So it is a win-win for MRI compared to truth biopsy. The next letter P is P for PI-RAD, and PI-RAD stands for Prostate Imaging Reporting and Data System. This was developed to standardize the way we interpret prostate MRI. It was jointly developed by the European Society of Urogenital Radiology and the American College of Radiology. It was first introduced in 2012, followed by update to version 2 in 2015, and the most recent update was version 2.1 in 2019. The PI-RAD's assessment categories are based on a combination of findings on multi-parametric MRI, including the morphological assessment with high-resolution T2-weighted imaging, in addition to important diffusion-weighted imaging looking at hypercellularity of the underlying tissue, and also the early perfusion in dynamic contrast enhancing imaging. This is a nice example of PARS5 abnormality consistent with clinically significant disease. On MRI, we can see a node to very low signal very well on the right side peripheral zone. On the left image, with corresponding restricted diffusion, low signal on the ADC map, which is mean hypercellularity, and also corresponding a significant early perfusion on dynamic contrast enhancement image on the right side. There has been improvement with updates in the latest PARS version 2.1, although some issues remain unresolved and new issues have also emerged. For example, we need to have more detailed protocols with optimization for 1.5T and 3T system imaging. We need to create a new category for lesions that do not fit into PI-RAD assessment. A PI-RAD M category for other tumors in the prostate, such as sarcoma or SCC. We need to include quantitative parameters beyond size to evaluate lesion aggressiveness. We also need more detail of how we assess the risk of actual prostate extension. We need detail on parameters for image quality and performance control, and there is a need for expansion of the system to other indications, for example, active surveillance and recurrence. So further changes to PI-RADS are expected to occur as more evidence become available. Despite the important leap forward, there are further improvements needed with MRI. In PROMISE trial, 25% of men with negative MRI had ISUP2 on template biopsy. In PRECISION, PARS2 were not biopsy, but many biopsies using MRI triaging remain negative. So can we minimize these negative biopsies? Also in PRECISION, there was only moderate agreement between sites and central read, meaning there was variability in skill set between community radiology and expert center. Many systemic review showed a wide range of sensitivity, specificity, and negative predictive value for MRI. Also, the positive predictive value of MRI remains low, between 34 and 68%, meaning that there are still unnecessary biopsies and over detection of insignificant prostate cancer. So can we improve further on these? And the answer is yes, we can. This is an example of different image quality from two different 3T MRI systems. Clearly, on the right side, the image is much better, would appear sharper, well-defined, better resolution compared to the left side, and therefore the image quality will affect the diagnostic performance of the radiologist. This is an important question. Is there a way we can further safely reduce biopsy so we can only biopsy those men who have significant malignancy? And the answer is yes, we can. This brings me to the next letter P, and P for PSMA PET. This is an important publication in 2012 from the Johns Hopkins Medical Institution, demonstrated PSMA Specific tumor imaging in vivo, and this is really the dawn of molecular imaging in prostate cancer. PSMA stands for Prostate Specific Membrane Antigen. It is a cell surface type 2 transmembrane glycoprotein. It is highly expressed, about 100 to 1,000 times higher in prostate cancer than in benign prostate tissue. PSMA expression also increased in metastatic and castration-resistant prostate cancer. This is an example of a PSMA PET scan. You can see on the left is the whole body MIP image showing the typical distribution of tracer with the lack of tracer activity in the brain and a normal physiological uptake in the major salivary glands, liver, spleen, kidneys, bowel, for example. And then we also have metastatic disease in the background with increased uptake in the prostate, also in bones. The emergence of PSMA PET has transformed the staging and restaging of prostate cancer, which I will discuss in further detail a little bit later on. But in early detection, can PSMA PET improve on MRI? This is one of our study from St. Vincent's, published a few years ago, demonstrated that PSMA PET performed very well or even better MRI in detection of intermediate grade prostate cancer prior to radical prostatectomy. Since then, we have strong evidence from international literature confirming the same thing. There are also small studies suggesting that combining PSMA PET and MRI together also improve further the detection of significant prostate cancer. This is a nice example showing concordant finding between MRI and PSMA PET scan demonstrating clinically significant prostate cancer on the left side of the gland. So the next letter P is P for primary, a primary trial. Primary trial is the first multi-center prospective phase 2 imaging trial led by Professor Louise Emmett from St. Vincent Hospital in conjunction with multiple other centers around Australia, including the PMAC. Primary trial looking at the additive diagnostic value of PSMA PET scan to MRI in detection of clinically significant prostate cancer. In the primary trial, 296 men with suspected prostate cancer were recruited. None of them had biopsy previously and no previous history of prostate cancer. All these men underwent MRI as well as pelvic PSMA PET studies. And the study showed that the combination of PSMA PET and MR together improved negative predictive value and sensitivity significantly compared to MRI or PSMA PET alone. The sensitivity was increased to 97% versus 83% for MRI alone, and 91% of negative predictive value for a combination of PSMA PET and MRI together compared to a 72% negative predictive value for MRI. The false negative percentage was 17% for MRI, and this was improved to 3.1% by the combination of PSMA and PET together. In the study, we also showed the strong correlation between the uptake intensity of PSMA PET, the SUV max, and the tumor aggressivity. This is a concordant finding in both MRI and PSMA PET with clinically significant disease in the right side of the basal gland. This is a different patient in the study showing discordant findings between MRI and PSMA PET. We have two positive lesions on PSMA PET scan on the right and the left side with no corresponding abnormality on MRI. So MRI was PARS2 features and abnormalities on the PSMA PET were Gleason 3+4 on biopsy. Another important finding from the primary trial is in the subgroup of men with a PARS2 and PARS3, meaning clinically significant disease is unlikely or equivocal. In PARS2, we found that 28% of men had clinically significant prostate cancer. In PARS3, up to 47% men with significant prostate cancer. And in this particular subgroup, PSMA PET scan was positive in 90%. Another subgroup of 38% of men with PARS2 and 3 that are negative on PSMA PET, 91% was true negative and 9% was false negative. And in this small subgroup of false negative, the cancer have low characteristics. They are small in volume, and most of them, 4 out of 5, was ISUP2, and only one patient with ISUP3. So these kind of tumors that were missing on the combination of PSMA PET and MRI have low overall low characteristics and may be selected for active surveillance, for example, rather than needing definitive treatment. This is another important finding from the primary trial, the positive predictive value for significant prostate cancer. With a PSMA PET with intensity of more than 12, regardless of the PI-RAD score, there is 100% probability of significant prostate cancer. With a PSMA PET intensity SUV max 9 or more, in combination with PARS 4 or 5 findings, we also achieve 100% prediction of clinically significant prostate cancer. So this raises the question of can we avoid biopsy or de-intensify biopsy in this subgroup of men that is strongly positive on both PSMA PET and MRI, like the way we do with a LIRAD with liver cirrhosis with LIRAD 5, where we don't need biopsy and we can proceed to definitive treatment. There are several recent small studies showing the feasibility of proceeding to radical prostatectomy without biopsy. In the study on the left, the patient, 25 patients were positive on both MRI and PSMA PET, proceeded to radical prostatectomy without prior biopsy, and all patients show ISO grade group 2 or higher in post-operative histopathology. The study on the right also demonstrated that biopsy-free prostatectomy is safe and feasible for patients that have been evaluated strictly by MRI in combination with PSMA PET scan. So the main message from primary trial is that it's combination of PSMA PET and MR together improve negative predictive value and sensitivity, and may allow for the safe reduction in a biopsy in an already MR triage population. The highest impact we see in the trial in a subgroup of men with PARS 2 and 3 by adding PSMA PET to this subgroup of men. There was significant improvement in detection of significant prostate cancer and potential to reduce biopsy in about 38% of men. The impact in PARS 4 and 5 is less. We still need to biopsy men with PARS 4 and 5 with negative PSMA PET, but when we have a strongly positive PSMA PET and PARS 4 and 5, meaning 100% prediction of significant prostate cancer, can we avoid biopsy or de-intensify biopsy in this subgroup of men? The primary study analysis utilized the cutoff maximum SUV max of 4, in which above we call positive, we think positive for significant cancer, and below 4 is probably benign. However, this method is not valid across unharmonized PET cameras and with variable PSMA ligands. Also, we found that with the SUV max of 4 cutoff, also reduces our sensitivity to pick up disease in peripheral zone. For example, the case on the left side here, where the patient have clinically significant disease in the left posterior midgland on MRI, although the evaluation on diffusion wave imaging was suboptimal due to hip prosthesis. On the PSMA PET scan, there is a mild focus uptake in this region. However, if you use the SUV max of 4, then this study is not positive for clinically significant disease. So is there a better way to read PSMA PET? And the answer is yes, in the form of primary score. So the next P is P for primary score. In the primary score, we look at the combination of the pattern of uptake rather than a SUV max cutoff, in addition to the zonal anatomy, to constitute the primary score. This is one of our recent publications, the primary score. And in the primary score, we propose a 5-point scoring system with a primary score of 1 and 2, suggesting it's a benign pattern of uptake, and primary score 3, 4, and 5 in red suggests that there is a presence of clinically significant prostate cancer. In the primary score 1 pattern is quite straightforward. We have very minimal low-grade activity throughout the prostate. In the primary score 2, which is also meaning properly benign, we have two categories. The primary 2A is looking at specifically the transition zone, showing relatively patchy or diffuse uptake with no abnormal focal uptake. In the subcategory of primary score 2B, this is specifically looking at the central zone where there is a benign pattern of symmetrical uptake at the basal gland level. So the primary score 2 is also suggesting it's a benign pattern uptake. The primary score 3 look at specifically the transition zone, and any abnormal focal uptake twice the background or higher, so the background transition zone or higher, is considered to be abnormal. In primary score 4, this is specifically looking at the peripheral zone only, and in this category, we do not look at the SUV max cutoff. We look at a pattern. Any focal uptake you can see visually, regardless of the SUV max, is considered positive for clinically significant prostate cancer. And primary score 5 is straightforward. This is any focal uptake in the prostate with SUV max more than 12. In the study, the primary score 5 with SUV max more than 12, we got 100% prediction of clinically significant prostate cancer. In primary score 4, we have improved our sensitivity, and the pickup rate is around 76% of clinically significant disease. The primary score 3 has a prediction of 38% of clinically significant prostate cancer, and in primary score 1, we still have about 8.5% underlying clinically significant prostate cancer. However, the cancer is small volume and often grade group 2. In the study, we found a better correlation between grade group on histopathology with primary score compared to prior score. For example, with primary score 1, there is only a small subgroup of patients with intermediate prostate cancer, whereas in prior 2 category, we can see quite a number of patients have significant prostate cancer, including high-grade tumors in grade group 4 and even 5. On the other side, with the primary score 5, we see that all patients have clinically significant cancer. In part 5 category, a high proportion of patients have intermediate prostate cancer, and also a small proportion had low-grade cancer as well, no malignancy as well. Just quickly for your information, we recently launched a free website for everyone to access at theprimaryscore.com. You can learn more about the primary score and how to interpret PSMA PET scan using primary score with our guided lectures and case discussion. In summary, the primary score reports by pattern rather than intensity and has higher specificity while maintaining sensitivity for PSMA PET alone. The kappa score for inter-reader variability is better in primary score than in prior score. We need to validate further the primary score in the low prevalence pre-biopsy population. Primary score is not expected to replace prior score because the primary trial cohort of patient is in the MRI triage population. Overall primary score, we think will improve the PSMA and MRI combined results. So far we have prior score, we have primary score, If we combine the two together, PI-RAD score and primary score, we have a new scoring system that we developed called the P-score. The next letter P, P for P-score. The P-score is our latest publication combining the PI-RAD score and the primary score together and see if we can improve further the detection of significant prostate cancer. So the combination of the two scores together forming P-score has improved the detection of significant prostate cancer. So the P-score from 1 to 5, with 1, we have 0% of clinically significant prostate cancer. A P-score of 5, we have 100% prediction of significant prostate cancer. And in between, P-score of 2, 3, and 4, we have 20%, 52%, and 96% with P-score 4 for detection of significant prostate cancer. For the ISUP grade group 3 or higher, the P-score is highly sensitive with 99% sensitivity. As we have been discussing with SU max more than 12, P-score 5, we have all clinically significant disease, ISUP 2 or higher, and a very high percentage, 93% of ISUP 3 or higher, so more significant disease. So the P-score, we think, is easily calculated and improve the detection of significant prostate cancer over both PI-RADS and primary score, and it should be considered when the PSMA PET is undertaken for diagnosis. I would like to discuss briefly the significance of visibility of cancer on imaging. There is a growing evidence that the visibility of cancer on imaging equate to more aggressive outcome compared to invisible cancer. So prostate cancer identified on systemic biopsy in the absence of visible cancer is in most cases genetically and phenotypically indolent, even if it contains elements of pattern for cancer. Conversely, visible lesions, particularly if also positive on PSMA PET scan, are far more likely to be clinically significant. The visibility of cancer on imaging, particularly MRI, due to combination of size and conspicuity. The visibility also determined by the tightness of cellular packing and the quality of the lumen. These features correlate with grade of tumor. The higher grade cancer are characterized by poor quality or absent acinar lumens. There are several recent studies highlighted the prognostic differences between imaging visible and non-visible cancer. There were 4 genes identified that predicted MRI visibility and were associated with worse progression-free survival and metastasis-free survival. The expression of genes associated with cancer aggressiveness correlated with MRI features influencing visibility. MRI-Invisible prostate cancer harbored a signature associated with a non-aggressive phenotype. The oncological outcomes after prostatectomy for significant prostate cancer differ between MRI occult and MRI detectable lesions, and judging the clinical significance of a negative prostate MRI based on histopathological surrogates alone might be misleading. MRI occult cancer was less likely to recur biochemically, to metastasize, or lead to prostate cancer mortality than MRI detectable cancers. So the story so far, MRI has an established role for diagnosis of significant prostate cancer superior to truth biopsy. In primary trial, we have demonstrated that by adding PSMA PET to MRI, improved overall sensitivity and negative predictive value. In a subgroup of patients, 38% of men with negative or equivocal MRI were true negative on PSMA PET, and this subgroup of patients can potentially avoid biopsy. Currently, we have a primary 2 trial running, looking closely at this subgroup patient with MRI parts 2 and 3, and we want to investigate in further detail about the true benefit of PSMA PET scan in this subgroup patient, how we can improve detection of significant prostate cancer, how we can help men to avoid biopsy, and also facilitate biopsy targeting the PSMA avid sites in a population of men with negative or equivocal MRI. So this is the current primary 2 trial at the moment from St. Vincent in Sydney, also Peter Max and some other centers around Australia. The recruitment started around early 2022. We're looking at about 660 men for this study, and we are currently halfway through the trial, so stay tuned for a result of this primary 2 trial in the near future. So the next stage is staging of prostate cancer. PSMA PET scan has established a role now in staging of intermediate and high-grade prostate cancer. This is an example of PSMA PET scan with patient with metastatic disease. You can see the disease is very intensely avid on the PSMA PET scan. However, the volume disease is very small. For example, the left side pre-sacral node is very small on CT scan. This is another study showing a strongly positive left-sided pelvic side wall node. However, on CT scan, this node is very small. I would like to discuss this very important trial, the PSMA trial, led by Professor Hoffman from Peter Mac, published in 2020, comparing PSMA PET scan to CT bone scan in staging of significant prostate cancer. And in this study, PSMA PET scan outperformed CT scan and bone scan in all aspects, including accuracy, sensitivity, specificity, pelvic nodal or distant metastases, less equivocal findings, changing management more often than CT and bone scan, and also overall radiation is lower, 8.4 millisievert compared to CT and bone scan together, 19.2 millisievert. So PSMA PET scan outperforming standard CT and bone scan in staging. Not only PSMA PET scan has a strong diagnostic value for staging, we also found it has predictive or prognostic value as well. With our previous publication in 2019 from St. Vincent's, we found that PSMA scan is superior in predicting a value for surgical response than Gleason score, preoperative PSA, or pathological staging. If we have extra prostatic disease on staging preoperative PSMA PET scan, it is independently predictive of a poor surgical response to radical prostatectomy, and it suggests that there is a strong need for a multimodality treatment approach. Every now and again, we see aggressive primary tumor with dedifferentiation. In this case, we have a large tumor arising from the right hemigland on MRI. However, on PSMA PET scan, the main tumor mass, which is a dark part on the MRI, is not PSMA avid, with the uptake on PSMA PET scan is only at the periphery. So this is telling me that this tumor is aggressive, is differentiating, is losing its receptor, and in this particular study case, we need to add another imaging modality to quantify the overall disease burden of this patient. So in this particular case, we added FDG PET scan for the overall staging, and on the FDG PET scan, there is increased uptake in the main tumor mass that is not PSMA avid. Also, we have another metastatic node in the right presacral region that was PSMA negative, but also avid on FG PET scan. So in this particular high-grade Gleason 4+5 tumor that using its original receptors, by using PSMA FG PET, we can quantify the whole disease burden within the prostate and also outside the prostate. I would like to spend a short time discussing active surveillance of prostate cancer. In active surveillance, the MR visibility and Gleason grade group 4 appears to be the determinant factors of event-free survival and time to prostate cancer treatment. The MRI-Visible cancer lesion appear to have a distinct radiological, pathological, and clinical trajectory. I would like to touch very quickly on a current active surveillance study called the PI-RAD trial from St. Vincent's, looking at adding PSMA PET scan to MRI in improving the active surveillance. And so far, analysis of 50 patients in favor of PSMA PET scan in addition to MRI. The next important stage is the biochemical recurrence after definitive treatment. Salvage radiotherapy treatment SBRT to prostate fossa and pelvic lymph nodes is the only potential curative treatment option in the biochemical recurrence setting. We know that the 5-year progression-free survival rate post salvage radiotherapy is over about 56% without ADT. But looking at the number closely, if the treatment commenced with PSA less than 0.2, this percentage is actually 71%, and it dropped significantly to 18% if PSA more than 1.5. So the low volume recurrent prostate cancer benefit the most from salvage radiotherapy. Going back to the early days of PSMA PET scan, we looking at the diagnostic performance of PSMA PET scan against a different PET scan called the choline PET in biochemical recurrence. At the time, the choline PET was the most proven modality for detection of disease recurrence in the biochemical setting. And in our study, we found that PSMA PETs outperformed choline PET in detection of local recurrence and pelvic nodes. Particularly at the very low PSA level, less than 0.5, the PSMA pickup rate was 50% compared to choline 12.5%. At the PSA of 0.2, the detection rate by PSMA is around almost 30%. So we normally advise to commence PSMA PET scan when PSA level reaching about 0.2. Not only PSMA PET scan perform much higher than choline PET in detection, the impact on management also quite significant. This is an important trial called the PROP trial that we involved in between 2018 and 19. This study was a multi-centered, multi-site international trial involving United Kingdom, Australia, and Canada, looking at the comparison between choline PET, PSMA PET scan, and MRI in detection of recurrent disease in the setting of biochemical recurrence. And in this study, PSMA PET scan outperformed choline MRI in detection within the prostate fossa and also outside the prostate fossa, as well as higher percentage change in management. This is an example from the study showing positive disease pickup on choline, PSMA, and MRI studies in the right seminal vesicle bed. However, PSMA PET scan detected a metastasis at the thoracolumbar junction that was negative on choline PET and MRI. This was proven to be a true positive after definitive radiotherapy with associated response on repeated imaging as well as significant drop in PSA level. Not only PSMA PET scan has been outperforming other imaging modalities in restaging of prostate cancer. It also has very strong prognostic value. In this study we performed a few years ago, PSMA PET scan was demonstrated to have to be independently predictive of a treatment response to salvage radiotherapy. A negative PSMA PET predicts a high response to salvage pulsar radiotherapy. Here are some examples of detection pickup of local recurrences. This is a case of prostate bed recurrence at the vesical urethral anastomosis. This is another case showing a small volume recurrent disease in the left semivesical bed that cannot be seen on a CT scan. This is a nice case showing penile urethral recurrence disease. This is a case with small metastasis to the right lung apex, too small to be biopsy. This was SBRT or had radiotherapy and with corresponding drop in PSA. So it's a positive result. What about biochemical recurrence in setting of negative serial PSMA PET? We see this subgroup of patients in clinical setting every now and again. Often these patients have well-differentiated low-grade tumors and have a higher expression of gastrin-releasing peptide receptor rather than PSMA receptor. With the use of a new tracer, the 64 copper SAR bombesin, which is a PET tracer that we use currently in research setting, we have been able to identify recurrent disease in this subgroup patient. In this patient with rising PSA, the patient has negative serial PSMA PET scan, including FDG PET scan, whole body DeWitt MRI, and bone scan. When the patient had the bombesin PET scan, there are a series of small abnormal lymph nodes in the left suprafossa, morphologically normal on ultrasound, biopsy-proven metastatic adenocarcinoma from prostate. Due to time constraint, I'm going to touch very briefly on castrate-resistant. We now know that androgen and PSMA receptors have a very close intracellular relationship. There are several studies now established that we can manipulate the PSMA receptor, increase the uptake intensity or density of receptor with androgen therapy. I would like to highlight briefly an important trial that recently published, the NCP trial led by Professor Louise Emmett from St. Vincent's and with additional contribution from 15 hospitals in Australia. By adding lutetium PSMA to enzalutamide, improved PSA progression-free survival significantly, providing evidence of enhanced anti-cancer activity. Lastly, I would like to discuss how we're monitoring treatment response. With SPECT imaging instead of PET imaging, we can quantify disease burden and monitoring the treatment response. For example, on the left-hand side, we have dose 1 treatment with total tumor volume of 594 mil cc, and after the second dose, we can quantify the disease with significant reduction overall tumor volume down to 206 cc. This is an important aspect of monitoring treatment response, particularly try to pick up low PSMA expression colon proliferation, which is a more nasty disease progression. You can look at this 3 SPECT study. At the dose 1, the disease is quite intense, but with dose 2 is dose 4, there appears to be reduction in activity, and you may interpret as treatment response. But when you look closely, there is a proliferation of lower PSMA expression disease, with the ribs become more confluent. You can see the ribs more the disease become more confluent in humera and femora. This means that there is underlying proliferation of low PSMA expression clones, and this is actual progression of disease rather than treatment response. I'd like to spend the last minute or two talking about two important new traces emerging in PET scan, PET imaging, currently on clinical trial. The first one is copper 64 PSMA. This agent has two moiety and therefore increased tumor uptake and retention. It has longer half-life and longer shelf life and higher resolution. It is safe and effective, and it can detect a great number of lesions with higher uptake when compared to our current PSMA agents. Just a quick note on the Clarity trial at the moment is a prospective single-arm, multi-center blinded trial, phase 3, looking at the copper 64 PSMA agent in staging of high-risk prostate cancer. And lastly is this tracer agent called gallium-68 PSMA R2 that show significant reduction in trace activity in major salivary glands, liver, and kidneys, while maintaining high dissection rate. And this is would be highly promising for a treatment agent to minimize side effects. Going forward to the very near future, I think the combination of evolving advanced imaging with radiomics, genomics, and AI will redefine the way we think what is insignificant and significant prostate cancer and what and when to treat. Thank you for your attention.